As you know, this outpatient department is visited by a large number of patients, and it reflects the image of the hospital. And it is, as mentioned in your block, it is known as the window of the hospital. So, since this is a very important area, I think we must start with this area, and I will request Professor Agarwal to introduce us what is the necessity of having a good OPD, what is the definition of outpatient department, and what are the various patterns of outpatient department.
Thank you, Dr. Arora. The outpatient department, accident emergency services department, in fact, are the two most important departments from the hospital administration point of view. And as our learners will appreciate that majority of the patients first come in contact with these two services in our hospitals, and as rightly described, that these two departments are like a mirror or a window into the hospital, and by a mere visit to these two departments, the patients, the community can make an impression about the quality and the efficiency of services being provided. Therefore, from the hospital administrator's point of view, your point of view, I think if we are able to keep these two departments in vibrant, efficient manner and provide good quality of services, I think the half of the battle is won with regard to the patient care management in the hospital. Coming to the outpatient department, it is also known as the ambulatory care service. You must have seen in your block, when you go through the block, it is described as the ambulatory care, and ambulatory care refers to the care of those who can be examined, investigated and treated in the outpatient situations, whether it is a OPD or it is a dispensary or it is a polyclinic. They are all coming under the umbrella of the ambulatory care facility. And if we analyze or look into a, I think, medium or a large or a district hospital outpatient department, I think there are two main problems which one encounters as a manager or as a hospital administrator, is that there are too many patients in the outpatient and too few facilities. Now, all this results into a situation that the patients have to wait for a longer time for service in the OPD. So, what we will discuss is mainly the principles of the planning of the outpatient department, the layout, the location of the outpatient department, the entrance to the outpatient department, the various functional zones of the outpatient department,
and of course the problems in the
outpatient department. So, these are some of the things which should be discussed, and then what should be the kind of a organizational flow of the activities in the outpatient department. I think these are some of the things we should concentrate. And to begin with, I will say that there are 3 or 4 important principles of the planning in the outpatient department or for the outpatient department. And the first most important principle of planning is form follows function. You see, when we are planning or designing an outpatient department, its structure, architectural design should be decided only in consultation with the people who are going to use it. So, the form or the shape of the outpatient department should follow the functions which are going to be performed. So, we should do a careful study analysis of the various functions which are going to be performed. I will give you one very simple example which will illustrate my point further, and that is, suppose we are going to plan for a ENT OPD. Now, ENT OPD also, besides the normal outpatient rooms, would also have a audiometry room. So, audiometry room, as you will appreciate, is a place where we carry out the investigations with regard to the hearing problems, and this room has to be a soundproof room, so that no external sound vibrations or any sound is able to from outside go inside. And therefore, when we are planning for this audiometry room, we have to keep in mind that there are no solid pipes passing through the walls, so that the outside vibrations can be transmitted which interfere with the results of the audiometry. So, a perfect soundproof cubicle has to be planned, and these specifications have to be given to the architect, so that he plans a room which is soundproof. Similarly, orthopedic OPD will have plaster rooms, the dental OPD will have the dental X-ray and other facilities. So, every OPD will have different functions to be performed, and those functions must be carefully reflected in the planning so that they are reflected finally in the architectural design. So this is one of the very important cardinal principles. The second important principles in the planning is maximum flexibility and expansibility. So what I am trying to say, that the workload in the outpatient department is going to double every 7 to 10 years, and if we don't tell these kind of a important future perspective, the architect will not be able to provide a facility which can be flexible enough to have additional rooms, additional facilities after 10 years or 15 years. So there should be a provision that either we have a vertical expansion, horizontal, and we can have some room for expansion. So that is what is the flexibility and expansibility. And then there has to be a simple internal and external traffic pattern, so that we don't rub shoulders with each other. There is a good movement which allows the staff movement, the patient movement, waiting areas, services to come, patients to be wheeled in, wheeled out, all those things. So simple internal external traffic patterns. And then finally we should try to also have lot of automation in the OPD with regard to the public address system, so that the patients can be called and they can have some kind of a digital display on which they can be their number for how long they are waiting, which clinic they have to go, and directional signs, registration automation. So these are the things which will reduce a lot of confusion in the outpatient departments. And when we have these principles of designing or the planning in the outpatient department, then we come to the location, then to the entrance. And the location and entrance is very important with regard to the OPD, because any outpatient department in any district town or any peripheral place should be so located that the community does not have to travel more than 20 minutes or 3 miles or 5 kilometers. So it should be accessible and one can easily go. There should be public transport, there should be other communication facilities, and then once the patient reaches there, there should be good in and out gates for the OPD, enough room to permit ambulances, the vehicles, etc. to go in. So in gate, the out gate, the entrance should be from the main traffic road, and there should be adequate parking facilities inside the once they enter the OPD or the hospital. So these are the location, the entrance. And the third point will come to the layout, the architectural layout. In the architectural layout, I would like to show you one transparency in which we have the designs given with regard to how we can plan the OPD and what are the different architectural considerations. I would like to say that the architectural considerations are important. We can have different architectural considerations which can be a single corridor, a double corridor, or the single or the triple corridor system, or the square, a rectangular kind of a architectural designing. With regard to the functional divisions in the outpatient department, the OPD can be divided, whatever space we have got, the OPD should be divided into 3 functional zones. This is the first drawing, which has a single corridor and which is having 2 rows of the rooms opposite each other, and the entry and the exit. Now this design, as you see, shows that there is a central corridor which will have, it will not be as narrow as this one, but there will be adequate seating arrangements, patient waiting area, and the patients go to the rooms, different rooms which face each other. But this design is having a drawback. This used to be the design in the earlier days, but this is not preferred anymore because this is very overcrowding. This would lead to an overcrowding situation, rubbing of shoulders. But if you see the second design, which is the second drawing, shows that there are 2 corridors, 2 peripheral corridors with entry from the peripheral corridors. Now you see here there are 2 peripheral corridors and the entry is from those peripheral corridors. So we have avoided the central corridor, and therefore the crowd now for these 2 OPDs is divided onto the 2 peripheral corridors. So this is an improvement over the first drawing, and if you see the third one, I think that is the best possible architectural design in these three, and in this the third drawing there is a central staff corridor. So, central staff, as you see, the central staff corridor with two peripheral corridors. In this kind of architectural layout, the staff traffic, that is doctors, the nurses, has been separated out from the patient traffic, which is entering from the two peripheral corridors. So, this would lead to much simple internal traffic flow and would avoid lot of confusion and would give lot of room for the staff to function. In this central staff corridor, there can be toilets, there can be coffee arrangements for the doctors, there could be some store room and these kind of facilities. And the peripheral corridors, of course, which should be little more wider. The minimum width of the waiting corridor should not be less than 12 feet, because there are some benches, some other areas where the patients can wait, and some clerk or attendants can regulate the traffic. So, these are the three drawings, but this is not all. You can have any kind of a pattern which the space would permit, the building would permit. You can have a rectangular kind of a arrangement, which I told you that in the rectangular kind of a thing, there will be rows or there will be rooms on the two sides, and then the central waiting area will have the benches, waiting hall, and then in the waiting area, in fact, what we can do is that we can have arrangements for certain the documentary films, we call it daycare facilities, projections, health education material, certain other messages can be conveyed through the various projections in the waiting hall, so that the patients can be benefited while they are waiting for seeing the doctor. So, this is the architectural considerations. Then I think I may come later on to discuss about the three functional zones, about the outpatient department, namely the public zone, the staff zone, and the joint use zone, and 2-3 more planning considerations I would like to share.
I think before we go on to the planning consideration, Brigadier Vega, I would like to ask you, what are the important functions and what are the problems, major problems in the outpatient department? As I understand, there is a jumping of appointments, there is a overcrowding of there, and patient has to wait for long time. And Professor Agarwal was rightly saying that time can be utilized by showing them some health education films or putting up some posters. That is one of the way of not reducing the waiting time, but making the waiting time more pleasant, or making best use of the waiting time. But how it can be reduced, and how the appointment systems can be introduced in this outpatient department.
Okay, thank you, Dr. Arora. I think before we start that, what could be the problems? One of the biggest problem of any outpatient department is the queuing, crowding. Now, that can be reduced if already Dr. Agarwal has brought out certain factors. Now, few more factors I would like to add into it. One of those things is our hospital is a horizontally laid out hospital. Second is it a vertical laid out hospital? Generally, in future, most of the hospitals which will be coming now will be the vertical hospital, because there is always a problem with the space. It has been estimated that generally whatever the number of beds you have, 3 times of that everyday OPD is likely to take. In addition, 2 to 3 relatives would also be bringing one patient. Now, they all will be crowding into the outpatient department. That means if there is a 200 bedded hospital, we expect 500, 400, 500, 600 odd, depending on the type of the hospital. Every day the number of OPD patients will be coming, and double of that means 1,000 odd people will be coming as a relative. Now, if it is a vertical hospital, total outpatient department must be segregated only in the ground floor. That means we must have all departments which are interdepartment relationship which they have with the OPD, they must be in the ground floor. There is a study which has been done by IIT Delhi on operational research on this, that was for a couple of years back, and it shows that what are the departments which are closely related with OPD. There are obviously diagnostic departments, that could be X-ray, laboratory, physiotherapy, the pharmacy, and these particular departments, whatever we have, they must be next to outpatient department, and they all must be in the ground floor. So OPD traffic must not go into the first floor onward. It must be cut out totally into that. And all the department, whatever there is related with the OPD, they must be around outpatient department. In fact, if we add up accident and emergency, people say it is called hot area of the hospital. Hot area of the hospital is where maximum traffic is available and round the clock traffic is available. There is activity round the clock. So if we take out an OPD and if we put in nearby same place our accident emergency services, they all will form into hot area where we can even add up one of the casualty ward, we can add up a casualty operation theatre in the emergency department. So OPD should also be somewhere nearby if possible to the accident emergency department, so that diagnostic and treatment facility can be shared by both accident emergency and OPD department. This is one part. Second part, this is what I'll come back to that, how queuing can be reduced. So queuing we are going to tackle that how we can have reduce the traffic, we can have interdepartment relationship so that people just don't crowd in particular area.
Second, before we go on to queuing theory, I would like to refer to Professor Talib, because he deals with the diagnostic services,
Okay.
and you mentioned that these diagnostic services should be within the close vicinity of the OPD services. They should be next to it. So, sir, where would we like to have exactly that, and what is the interrelation between the outpatient department and the diagnostic services, and how it improves the image of the hospital, and how it improves the efficiency of the outpatient department?
It has been very rightly said that laboratories should be within the vicinity. I just go and add the word within the vicinity, meaning thereby that a person attending for any ailment, whether it's a surgical or whether it's a medical or it's an orthopedic, gyne, patients almost 1/3 is being directed towards the laboratory investigation. Now, once these patients are directed towards the OPD laboratory, I introduce here one or two words in the laboratory, that the laboratory is a workplace for determination of the investigations, which is adding to the monitoring or the diagnostic facilities for the working physician. Now, once this is being added to that, the OPD laboratory, the ward laboratory, the emergency laboratory will deal separately when we come to that point. I come back to the OPD. When we have a very large number of the patients attending to the OPD, there has to be certain system of arrangement where, which has been just said, that we must reduce the time of the patient, which is very important for us, that how we are going to reduce the time of the patient for a registration system, because there is a one principle that no sample should be taken or should be processed without a registration and numbering of the patient, because there should not be any mixing of any system. Now, once there should not be any mixing of the sample, there has to be a involvement of a registration and processing numbers. Now, if the patient has already a number which has already been seen by a physician doctor, now he has to again come back to the laboratory and again put a number. But this is a must, because without a number you cannot process any sample. Now, in a large hospitals, when round about 300 or 400 patients are attending at a time, the time interval of the registration from 9 to at the most 12 o'clock. That means there are only 3 hours which is being there. So, in a 3 hours, if 300 patients are there, you can understand there is not only a registration, the process has to be done, the results has to be taken out, and the report has to be given on the same day, because you cannot have collect the blood and give the report. So, we must have a certain sort of a system where we must help the patient that if the patient has attended on a particular day, he must be relieved and given a report on same day. So, there are certain automation has now been developed. Type of automations we will discuss it later on, but registration is a must. Then entering the sample and processing, there is a procedure which is called as a phlebotomy. That means taking out of the blood of the patient. Then there is a certain type of the investigations which are there. So, we have evolved a system which is being followed in large number of the country area, which is called as a central collection system for a large hospital. I am not speaking any hospital which is less than 300 or less than 200. It is a large hospital beyond say 700 bed capacity hospital or any medical college or any large institution. A central collection system in a OPD. So, that means whether the laboratory is a histopathology, whether it is a biochemistry, whether it is a clinical pathology or a laboratory medicine, all patients in one prick should be taken a blood. That is a single phlebotomy procedure. And the report system should give the same report at the same time. That means if the blood has been collected at a one place, the report should be available at the one place. And that is the system is available in a large hospital. And that is what a system which is considered as the, if I do not say a best system, but a better system considering the earlier system, where the patient is taken as a guinea pig going to one laboratory, other laboratory and the third laboratory, and the blood is being taken at several places. Now, patient's blood at one place, giving the report at one place, processing may differ, may go to respective laboratories, and the numbering system, you may evolve any system. Now, I will discuss at a later point what are the various automations which has arrived at OPD and at registration, at processing. That means all intake system, processing system and the reporting system. We will discuss it later on. But as far as OPD is concerned, where I was saying that in an OPD, if we give a better system of a registration, if we involve automation or say computerization in bar system coding at the time of registration in a larger hospital is a better system. And there are certain big hospitals which has evolved this system. I think even the private clinics have started a bar coding of the indexing at one place, and this is what an OPD registration system. So,
I think all these things need to be taken into consideration while we are planning OPD. Before I think that's a very valid point. So, we were talking about Brigadier Vacancy, we were talking about the queuing theory and the large crowds waiting there. So, we will continue with that. And
okay, the queuing is, the theory of the queuing is that there are a lot of people which get collected in the various counters in OPD. Now, the aim of the management should be not only reduce the waiting time at the OPD, but OPD should be running in such a manner that there is a less crowding in patient. That is what is the latest. That means maximum patient must be dealt with in the OPD. Most of the facilities must be created in OPD. In fact, that reduces the cost to the state, that reduces the cost to the person, that also reduces the cross infection or nosocomial infection, and the patient is always better looked after in own home environment, having a domiciliary care or otherwise, and that is how the daycare concept has come. That means we must have OPD, all the facilities, diagnostic, treatment, where inpatients are minimized. Now, how do we do it? Now, first of all, let us see what is the queuing in OPD. Now, as in a traditional hospital, somebody will be registering the patient, then he will be going and waiting for some of the doctor to see. Person will go for the investigation, and then he will go to pharmacy or treatment, or maybe that he will be referred to some of the specialist and super specialist clinic. Now, this can be reduced by two methods. One method, people say, the appointment system. But appointment system, even in USA, has shown that it has failed. It has not gone to that extent which was expected, and various journals have reported that appointment system except in some of those super specialists or other hospitals. This cannot be taken care of into the general hospital or general OPD. The next one is that after the person has registered, we must have number of people registering a patient, so the patient doesn't wait there in registration. And this must be in a big lobby where this registration can be done. After your registration, there itself there should be some sort of a filter clinic. There should be a general medical officer, or maybe if general medical officer is not aware, somebody, an expert nurse could be there, who could immediately sort out a patient that he need to be going to the medical OPD, a surgical OPD, or maybe a super specialist OPD like endocrinologist or neurophysician or neurosurgeon. So she or the medical officer or expert nurse in filter clinic must be able to sort out. If there is a medical officer available, then added advantage would be the number of cases he can dispose of which are common in nature. That means in filter clinic there should be number of medical officers who can dispose of, and there is one study which has shown 60% of patients can be disposed of. Common cold, diarrhea, etc., which is of routine nature. After that, some of the patients which will require a specialist, they will go to the general OPD of the specialist, medical OPD, surgical OPD, pediatric or gynae. That means the concept should be there that most of the specialists should be available within the same vicinity or location under one roof. So cross consultation should also be finished on the same day, and that is the concept of the polyclinic. That means a patient who has come, registered himself, if doctor could dispose of, disposed of. If doctor could not dispose of, at least the basic specialist could be able to dispose him of on the same day. So the concept of the polyclinic is also reduces the person's waiting time, and also person need not to stay in the system for a long time.
Is there any role of satellite hospital also in this?
Yeah, that is also where you are very right. The satellite hospital is another factor that you can also really create it. That different tier type of hospital you can have. The satellite hospital can taken care of, and they need not to throng to this all big hospital like Safdarjung or AIMS that everybody wants to rush there. If you have nearer their location, they can all look after that. And subsequently, once they have, then it can be referred to the super specialist, whatever. That of course will be probably afternoon or whatever the particular days, they may not have every day, depend on the workload. The treatment also should be done in the center, which may be called as the daycare center. In fact, even Apollo is now saying that we must have daycare center all over Delhi rather than opening up the hospitals which have more problems of housekeeping, etc. So they are opening up one, they have already opened one in Janakpuri in Delhi. Now the daycare center can take simple procedures like lithotripsy, laparoscopy surgery, or other procedures which are required to be done. So the treatment procedures can be done in that. With the result, the inpatient problem will be reduced if we can tackle them and be cheaper. So the total gamut must be, now after you have seen the whole queue, again shift to the diagnostic, again to the laboratory or the X-ray, and after they have already given the person a diagnosis, it goes to pharmacy. So the queue shifts from the morning from registration to the specialist, after that goes to diagnostic, and after that by the afternoon it reaches to the pharmacy to get the proper treatment. That the only rule of thumb remains that you may have to do a scientific study that should be increase the number of hours for that particular facility, and the patient should move faster to this facility, so the patients are spread out and more like, say like laboratory. I mean, one of the hospital I have seen, they say after 11 we will not take a specimen. Can we have number of more hours? It all depends on the management. Do you have that much of resources and that much of facility?
Professor Agarwal, would you like to add something to planning consideration and what are the
Yes.
managerial issues involved in the outpatient department?
That's right. There are a lot of managerial issues, and I think if we keep those simple issues, management techniques, and other factors into consideration or in our mind, probably will reduce a lot of chaos. First thing is that when I was talking of the planning considerations, we should remember that the space requirement for a new facility or even for the existing, when we are going for the expansion, would depend on certain broad guidelines, what we call the rule of thumb. Now, the rule of thumb says that for a population of 1,000, a population of 1,000 will create 3,000 outpatient visits in 1 year. That means one patient will go to the outpatient department 3 times in a year. So, if the population of a city or a town is 1 lakh and we are going to construct the outpatient department for that city, of course, we have to take into account the existing healthcare facilities, existing health manpower, but even then this is the broad guideline that if we have a population of 1,000, there will be 3,000 average number of outpatients. Average number of the outpatients will be 3 times the population. So, if the population, say I was saying 1 lakh, then it will create 3 lakh outpatient visits. Now, how can we calculate the space requirement which is required as a carpet area or as a floor area? So, it is the rule of thumb says 2/3 of the square feet per outpatient visit per year. 2/3 to 1 square feet depending upon what kind of facility you want. So, if we take 2/3 of the 3 lakh outpatients visit in a year, so 2/3 of the 3 lakhs would be 2 lakh square feet of area. I say that 2/3 square feet per outpatient visit per year. So, if the outpatient visits are 3 lakhs, then we would need 2 lakh, 2/3 of 3 lakh would be 2 lakhs square feet area in which we will have to construct the various facilities in the outpatient department, and this area will be then divided into 3 functional zones. The 3 functional zone would be the public zone. Public zone would include the entrance lobbies, the waiting area, the parking facilities, and then of course we will have to have the public toilets, the circulatory area. The second area will be the staff zone. The staff zone would include the facilities like seminar room, the duty room for the doctors, then the staff toilets, the stores, various facilities. The third zone, which is the busiest zone would be the jointly used zone, what we call the joint use zone, and that will have the patient's examination room, it will have the treatment rooms, it will have the dressing, the dispensing and other facilities. So, if we divide this area into 3 zones, as I said, the public zone, the staff zone and the jointly or joint use zone, this is how this will have to be divided. Then there is a guideline as to how many doctors would be required for the outpatient clinic or for the OPD. Now, there is again a rule of thumb that a population of 1,000 would need 3,000 would need 1 medical officer. So, if the population, as I said, is 1 lakh, we would be needing the doctor's population or the doctor's requirement would be 1/3 of the actual. What I wanted to say that for a population of 3,000, we would be needing 1 doctor for only catering to the outpatient services. And these doctors will not be only sitting in 1 OPD, then we will have to divide the requirement of the doctors for the main outpatient department in the hospital and then the satellite clinics, which Dr. Arora was mentioning, that we will have 1 main OPD and then the outside peripheral dispensaries in which these doctors will be located. So, these are the staff requirement, the space requirement and the various functional areas. One of the managerial important managerial problem which faces the average hospital administrator is to reduce the waiting time of the outpatients in the hospital. The waiting time, Dr. Brigadier V.K. Singh has mentioned about it, that some queuing theories have to be applied, and but let me tell you that one of the simple and most important technique in any outpatient which is overcrowded is to have a filter clinic or what we call the screening OPD. The screening OPD in a busy hospital can be managed by the general duty medical officers, the house surgeons, the junior residents, and these are the people who will sit in the morning and screen all the patients who are coming to the OPD. And as very rightly pointed out by Brigadier V.K. Singh, around 40 to 60% of the patients coming to the outpatient departments are suffering from minor ailments, and these are the cases which can be screened out by the general duty medical officers, the house surgeons, the junior residents. And then those who need the referral or examination by the specialist should be sent to the consultants and the specialist for examination. By this, we will be reducing the waiting time considerably and disposing of the routine type of cases to their satisfaction. So, we will have the less waiting time, more patient satisfaction, because the deserving cases will be going to the consultants and the specialist, and the patient satisfaction would obviously increase. The second important thing which was touched upon during the discussions is that we should try, besides the screening of the patient in the outpatient department, also regulate the traffic of the patient by increasing the registration timing in the outpatient department. The registration timings, what we are seeing in the Delhi hospitals, for example, and many other hospitals, if the OPD is starting at 9 o'clock and the OPD time is from 9 to 1, then the registration closes at 11 o'clock. Now, what happens during the 9 to 11, these are the 2 hours where there is a maximum overcrowding and maximum congestion of the patients. So, it is recommended that we should increase the registration timings and close them only half an hour before we are closing the outpatient department. And then before we do that, we will have to take the community in the catchment area of the hospital into confidence and tell the community that, well, our OPD registration timings will start half an hour before the OPD beginning, that is 8:30 a.m. in the morning, and will go up to half an hour before the OPD closes. If it closes at 1 o'clock, 12:30. If it closes at 2 o'clock, then it should be 1:30. So, the patients will know. So, those who are in the morning wanting to go to their offices, or the children for the schools, or the women for the their working places, they will come in the morning. Then we can segregate the new cases and the follow-up or the repeat patients, that the repeat patients can be told to come after 11 o'clock. The new cases will come in the morning. So, there are various mechanisms by which we can stagger and then have less waiting time, less congestion, and the flow of the patients. The queuing will also address to the system the arrival rate and the service and the disposal rate. So, our arrival rate of the patients in the OPD should match with the disposal or the examination or the service rate in the hospital by the doctors and various other places. So, arrival and the disposal should match. Whenever there is a mismatch between the arrival and the disposal, there will be overcrowding. So, there should be the screening OPDs, increasing of the registration timings, staggering the new cases, the repeat cases. These are the simple managerial interventions which can be taken.
I think one of the intervention when you are mentioning about the service rate can be that some of the responsibilities can be delegated to the paramedical staff like nurses, like taking the BP and blood pressure.
Sure. I think this is also a very good suggestion.
So that you can increase your service rate and thereby keeping a balance between the incoming patient and disposing of.
And the daycare facility which Dr. Brigadier V.K. Singh mentioned is a very important facility from the point of view of the hospital efficiency, economy, patient satisfaction, and then you can prepare the patient in a manner in the OPD and then refer them to the daycare facility. They can be examined, investigated, treated, minor procedures can be carried out, and the patient is discharged the same day in the evening. So, this is how is a very good system.
I wanted to just add at the point that as I have said earlier, that there is a registration also for the laboratories, and again they add to the increase in the timing of the patient in the queuing. In a large hospital like Southern Hospital, we have now started the timing, instead of 9 o'clock, it is starting at 8:30. With the result, we have seen for more than I think 6 months or so, the patient's queue is now reduced. 8:30 is an starting time of the registration of the laboratory registration, and closure time, as you have said, that 1 o'clock is the closure time. We have seen 12 o'clock is the closure time. We have increased the registration up to 12 o'clock, which earlier it used to be 11:30. So, now the large number of the patients have been now accumulated. And also, sometime what happens, the patient investigation is being done on a fasting condition. So, patient may not be fasting at that time right up to 12 o'clock, then they are asked to come on the next day, and that is the time when they come at 8:30, and those crowding to go again to the another referral physician or this and that is also being reduced. So, there is a diversification, as you have said, of the various queues in a different way. So that is one of the points which I would like to add, that the diversification of the queues, the registration system, and the timing which has also been already increased in this system.
The outpatient department needs to be a compact unit having all the facilities at one place. And what are the major problems? That is the increased waiting time, and those can be reduced by appointment system, that can be reduced by having daycare centers, and then also by regularization of traffic also was another important issue. And then concept of having all the interrelated departments within the same area, so that the patient need not to move here and there is no mixing of the traffic. All these concepts need to be taken into account when we are planning our outpatient department.